So we ended with the word intravenous, and the only reason we introduced it right there is because I wanted to explain to you what an intravenous pyelogram is, the abbreviation IVP you see here. And so that's usually how it's ordered. The doctor will order an IVP, or they'll ask a medical assistant or nurse to order an IVP on a patient. So intravenous was important because in this particular situation, we're using an intravenous form. We're going to start basically an IV, an intravenous line, in order to induce contrast medium. And then we're going to take a series of x-rays at timed intervals of the urinary tract and collecting system inside of the kidneys. So this is a fascinating study. I'd always wanted to see one, and now I've had the opportunity to do them a few times, and it's kind of cool. We start an IV in the patient. We give them contrast medium. Of course, it goes into a vein, and we know veins go directly to the heart, right? And after they pass through the heart, they go to the lungs. And then after the lungs, it goes back to the heart and then out to the body. So the contrast follows that entire route. What we're interested in is when the contrast hits the aorta. And we usually, when we do an IVP, we do the injection, the intravenous injection. And within about 60 to 90 seconds, we get that first picture, because within that amount of time, we already have contrast medium coming into the kidney to be filtered. So it moves through pretty quickly. And I'd have to check my protocols exactly, but it's somewhere around 60 to 90 seconds that we get that first image. And then we can take consecutive images and watch that contrast as it fans out through the kidneys and as it gets filtered and then drains down into the urinary bladder and so on and so forth. So depends on what the doctor's looking for, then that will determine how far we go. But some of the things they might be looking for are diseases of the urinary tract, kidney stones, tumors, infection, or structural deformities. So an IVP is going to start with some form of urinary dysfunction. It's not going to be necessarily dysuria or polyuria, because we're going to work you up for a urinary tract infection if you show up with those. But if it's flank pain, fever, passage of oliguria, so passage of very small amounts of urine, IVP is probably going to be indicated, provided that the patient can pass any urine at all. If they can't, then they may not do this study at all. This is a fascinating study because you can see the contrast fan out, as I said earlier, in the kidney, and it's really interesting to see that function happen. A blood test, so a BUN. This is something that we're going to do to test kidney function. Before we give you any contrast medium for any type of study that's going to be intravenous, we're going to want to get a BUN and a couple other blood tests to make sure your kidneys are functioning correctly. The estimated glomerular filtration rate, EGFR, there we go. EGFR is a standard that we use now. EGFR is calculated from a BUN, which you're looking at right now, blood, urea, nitrogen. So what this is talking about is how well are the kidneys filtering. This is a blood test, measures the amount of urea in the blood. It demonstrates the kidney's ability to filter urea from the blood for excretion in urine. If you have a really low BUM, and if you have a really poor estimated glomerular filtration rate, and EGFR, if those are low, we are not going to give you contrast medium intravenously, because you're probably in kidney failure, or there's something, it could be acute or chronic kidney failure. Either way, we're not going to give you that contrast because it may have an adverse effect on the kidneys. So while the intravenous pyelogram is very useful in looking for structural deformities and things like that, if it's kidney disease that we're concerned about, they're not going to do an IVP because of the risk factors in damaging the kidneys permanently. So we always do these blood tests, and every patient has to do these blood tests, especially the BUN, before we can give you contrast in an MRI or a CT or a fluoroscopy exam. We have to know your kidneys are functioning at least to an acceptable level. They don't have to be perfect, but they have to be an acceptable level. So that's the reason we have a BUN. If you're ever in the clinical setting and you're ordering a blood test, you're looking at results or reciting results, you never want to call this a bun. It will identify you as a rookie in the room immediately. It will get everyone's attention. They'll realize that you are probably new to the trade. We always call this a BUM. Occasionally you hear someone say bun, and we're like, okay, we know what you mean. You'll probably get a rough time from a few people, but you'll eventually learn that it is called a BUM, and that's how we refer to it. Now, we talked about hypertension, we talked about peripheral resistance. So it's a hydraulic system. Speaking of the cardiovascular system, blood flows in certain ways. If anything slows down the blood flow, then it's going to raise the blood pressure. There are different forms of hypertension we've talked about. Essential hypertension is just general hypertension. We have no reason it's happening. Peripheral resistance means we have resistance out there somewhere. So there's a kink in the hose, if you will, and the blood's not flowing through there well. It's backing up into the heart and it's raising the pressure. Renal hypertension is in its own category. It's kind of like peripheral resistance, but not exactly. This is high blood pressure that results from kidney disease. So probably hypertension is already present, possibly diabetes. As I said before, both affect the kidneys in really bad ways. So in renal hypertension, as the blood's trying to filter through those little glomerular pouches I showed you before, the Bowman's capsule, in other words, as it's trying to go through, capillary beds are bursting because the blood pressure is too high. Now blood can't flow through as smoothly as it did. Now the kidney's becoming dysfunctional. So renal hypertension. The blood flow is going great until it gets to the kidneys. The kidneys need to filter that blood, but they're unable to do so because they're starting to deteriorate. Therefore, they're resisting the blood flow and the blood pressure is going up. So that's renal hypertension. A very specific type of hypertension that has to do with kidneys failing. And I'll just add that it's usually a secondary form of hypertension. Usually there's a more primary form, essential hypertension or peripheral resistance. But for whatever reason, high blood pressure turns into now really high blood pressure as a result of renal hypertension. In some cases, the hypertension is renal hypertension in and of itself without any other complications. Those do occur as well. If you have that, we're going to give you a renal scan. This is a radiographic scan of the kidneys after an IV injection of a radioactive substance. Now, this is not the IVP I showed you earlier that we're putting contrast medium via IV. This is a different type of study. We are using IV, but this time it's a radioactive substance with a very short half-life. And so we're not putting radiation into the patient. The patient is radiating radiation and we're reading it. It's a little bit different. Sounds kind of dangerous. It's on the risk-benefit scale. If you have perfectly healthy kidneys, we would advise that you don't do this because we don't want you to have that contrast. That contrast is not going to cause any sort of major complications typically. But all the same, it's a radioactive substance. It has a very short half-life and your body rids itself of it in a matter of hours and the residual in a matter of a day or two. But if you are in kidney failure, it won't damage the kidneys any further, but it might give the doctor really good information. So they inject a radioactive substance. They want to assess renal function and perfusion. And I mentioned perfusion in the cardiovascular chapter as well. Perfusion is your ability to move liquids and fluids to the extremities or to be able to move liquids or fluids through vessels. So you have perfusion in the cardiovascular system. You have it in the renal system. So if they suspect renal failure, renal hypertension, or following a kidney transplant, they're going to do this type of renal scan. You see it depicted here. There are two kidneys here outlined. The one on the right is completely dysfunctional. You see there's a little bit of blue patch within a green field. That's a renal scan that's saying there's no function here. So that is essentially a non-functioning kidney. And if you look at the one on the left, and here they've mislabeled them. It says left kidney. It really would be the right kidney because we're looking at the patient anatomical position. But all that aside, that other kidney that has all the bright colors, that one's still functioning. It has some dysfunction around the outside borders, so the cortex is starting to fail a little bit, but the function of the kidney is still good. So that's what a renal scan is going to look like. It's part of a type of medicine we call nuclear medicine. And once again, nuclear medicine involves a radioactive substance in the patient, and we read the radiation coming out of that patient. It may sound dangerous, but it also many times has been a lifesaver because it's the way they can find tiny tumors that otherwise wouldn't be seen until they were causing big problems. Of course, what we're trying to avoid, but what in this case in the renal scan and other types of tests, what we're looking for and we're trying to prevent is end-stage renal disease, ESRD. This is advanced kidney disease. The kidneys can no longer function. They cannot filter the blood any longer. That is not conducive with life. So we have to have an alternative to try to help this patient. So dialysis or renal transplant is the two options here. We're going to look at renal transplant first. So in that picture on the right, you're seeing a human kidney about to be transplanted. A renal transplant is an organ transplantation of a kidney on a patient with end-stage renal disease. It's also called kidney transplantation. It doesn't happen that often. The reason being is that if you're going to transplant any organ, it needs to come out of a younger, healthy person. So someone in their 20s, maybe early 30s, someone who's maybe over age 40, 45, they might be an organ donor, but their organs may not be useful because of the wear and tear on them. So unfortunately, the best renal transplants, the best organ transplants happen as a result of someone dying a very early death. So in that sense, it's kind of a sad thing. On the other hand, this might save a life, so it's kind of a good thing. Once again, there's that balance in medicine between good and bad, and sometimes there's decisions have to be made that don't always benefit the patient, or unfortunately, there's a tragic accident and someone young dies, but they save another life. As I said before, one kidney can be removed and you can survive with one kidney. It's not optimal, but it's possible. If both kidneys fail, there's only one of two things. Renal transplant is one option. The other is dialysis, a mechanical process that filters blood and regulates body chemistry when the kidneys fail. This is essentially a mechanical kidney. It replaces the work that kidneys used to do, removes excess fluids and metabolic waste, extra electrolytes, everything a kidney would do. This does it mechanically. Dialysis is the end part of end-stage renal disease. Sometimes people are on dialysis for days or weeks. I've heard of people, and I know people who work in dialysis centers. I've heard of some cases that have lasted years, where people have done dialysis 3 or 4 times a week, and they've managed to extend their life years. Generally, dialysis, though, is not referring to longevity. It's usually just a way to support the kidneys short-term, to give the patient extra time and to try to keep them alive and healthy for as long as you possibly can. My friends who work in dialysis say it's a lot like working in oncology. You get to know the patient really well, and then one day they don't show up again. And we all know that that means that the end stage that they were in has probably completed its course, and they've moved on. So anyway, that's just an emotional, personal note. Dialysis is the procedure. Hemodialysis is what it's called specifically. So machine is filtering the blood. This gives a little bit different depiction of it. The previous slide shows what it really looks like. I'll flip back for a second. That's what it really looks like. This is a more sanitized version. It's talking about the same thing. You also have a lining in your abdominal cavity, which is much like the lining you have in your thoracic cavity, the pleural cavity. It's called the peritoneum. And there is a form of dialysis called peritoneal dialysis, and it uses the lining of the abdomen, in other words, the peritoneal membrane, to filter blood. So the peritoneum in and of itself is much like the pleura and the lungs, functions much the same way, and it can be used for dialysis. I had a student who does this type of dialysis explain it to me one time. It's a long explanation I'm not going to go into. You just need to know this information for the test. If you want to know more, you can research it online. There's some really good articles about it. Just when you do online research, pay attention to the source, because there's also a lot of wacko stuff out there on the internet that doesn't make any medical sense at all. I would recommend going to the National Institute of Health, NIH.gov, I believe. And there you can research medical topics and get reliable, good information. And if you want to know more about peritoneal dialysis, you can explore it there. So there are no abbreviations. I already gave them to you throughout the lecture, plus those ones about medical terms are your abbreviations for this week. Everything you need to know about the urinary tract system for next week's exam is included in this slideshow, plus a few other fun, interesting facts. So that's all we have for this chapter. So we're signing off on Chapter 7, and I'm going to get these posted shortly so you can take a look at them. And yeah, we'll be back next week, and we'll be covering the male and female reproductive systems, Chapter 8, Parts 1 and 2.